Hi, good morning, everybody, and good afternoon to those on the, or actually, no, good morning, sorry, it's early here on the West Coast, so it's good morning to the entire country. My name is Vin Gupta, and it is fantastic to be here with a distinguished panel of experts in the space of health technology. I cannot wait to get started on our seminar entitled Using Advancements in Technology and Therapy to Help Improve Cardiovascular Disorders in the Community. We have a really distinguished panel of guests who I will be introducing shortly. I did want to just begin with a primer on what you're going to hear today and themes that we're going to hope to hit in the next roughly hour or so on this kickoff for the forum's annual summit. This forum and this time and the time that we live in right now is unprecedented, of course, for all of us in the country, but particularly those of us involved in healthcare in some capacity, either clinically or on the innovation side. This is a time like no other. And so this particular conversation focused on improving cardiovascular outcomes in community-based settings using technological innovations. I think we couldn't have this conversation at a better time, because I can say as an ICU doctor, at least part-time, when I've been in the ICU caring for COVID patients, often these are individuals who are underserved, frankly, don't have access to broadband technology, are challenged to access basic telemedicine platforms. And that's part of the reason why they end up in the ICU. They've deferred care for a long period of time. Many come in with pre-existing cardiovascular disease or pulmonary disease. And if only, I think to myself, if only they had a connected device so that they could monitor their physical activity, they can give them some sense of potentially their heart rate, their resting versus exertional heart rate, so that they could get a sense of, okay, and some surrogate sense of their conditioning status. If only they had access to that, if their insurance plan, if they were insured, subsidized the cost of it, if they were able to otherwise independently afford these types of innovations, maybe they wouldn't have ended up in the ICU with a bad outcome because of this pandemic. So again, lots of discussion points that I think we can delve into. Because we're starting a bit late, I want to jump right in and introduce our panelists, and then I'm going to ask them to make a few minutes of introductory remarks. But we're joined today by Celina Gorre, who's the Chief Executive Officer of WomenHeart. I'm going to let Celina go into a bit of detail in just a moment on her background. We're also joined by Dr. Michael Jaff, who is the Chief Medical Officer and Vice President of Clinical Affairs, Technology and Innovation at Boston Scientific. We're also joined by Dr. Kweli Thompson, who's Vice President and General Manager of the Cardiac Resynchronization Therapy Initiative at Medtronic. And then finally, Dr. Robert, I apologize, I'm not going to say your last name correctly, Stoekenbroek, who is a physician specializing in the prevention of cardiovascular diseases. And Dr. Stoekenbroek decided to join the medicines company to focus on the development of new therapies to prevent cardiovascular disease in his current role as medical director at Novartis. So really distinguished panel here to talk about critical issues of improving cardiovascular outcomes in community settings through innovation. Very interesting time again. Celina, I'm going to throw it to you, and then to Dr. Jaff, Dr. Thompson, and then Dr. Stoekenbroek.
Thank you so much, Dr. Gupta, and good morning to everyone on the panel and to all the participants. I'm Celina Gorre, and as the CEO of WomenHeart, I'm very proud to lead the only patient-centered organization in the US providing support, education, and advocacy for women living with and at risk of heart disease. And maybe I'll just take a few minutes to share with you our experiences that we've had. Or Dr. Gupta, do you want to go through the other intros first?
No, please. I think what we'll do is we'll just go through individual. You do your introductory remarks. Perfect. And we'll go. Yep.
Great. So I wanted to just take the moment this morning to share with you WomenHeart's experience in the last several months with really the confluence of two major shocks to our society, right? We've got the COVID pandemic and social unrest due to issues around race and equity. And quickly, WomenHeart realized that we want to make sure, first and foremost, that we continue to serve our community uninterrupted. So first, what we did was we switched all of our programming to into the virtual space, as I'm sure the majority of patient advocacy organizations did around the country. What that meant was we trained current champions who had been running in-person support groups to be expert in running Zoom support groups. We also launched a series of webinars that we called Heart Talks that connect experts to our community to answer any questions that they may have had during the COVID crisis. And then we also created an app that transitioned our signature program called Sister Match, where women with heart disease can find peers out in the community to make sure that they had a friend or a mentor to help them in their heart journeys. And we also, importantly, recast our signature training in partnership with the Mayo Clinic to bring on new champions, which is what we call our volunteers, to continue to meet the needs of women with heart disease across the country. We also communicated to our community our distinct desire to better understand how we can most effectively serve women with heart disease in communities of color across the country. Much of that entails identifying the social determinants of health that we can address as an organization, and then to design effective solutions to more effectively tackle those head on. And it turns out that providing our support services virtually goes a long way to addressing some of these disparities, including those who may be time poor, those who may lack reliable transportation or live hours away from any of our support groups, and those who may need childcare as well. Of course, this also magnifies other challenges, including connectivity and adequate access to devices and computers, and we're beginning to look at how we can address some of those gaps as well. But one great question that I hope we'll delve into more directly is whether increasing access to each other and connecting sort of in this virtual world will result in a more diverse community, and will de-emphasize some of the difficulties achieving that the diversity that I think we are all aiming for. But one thing we do know is that in the last 6 months, WomenHeart, and again, I suspect all of our peers in the patient advocacy space, have looked at virtual programming and diversity, equity, and inclusion programming as a vital and indeed permanent component of any strategy that we go forward with in the foreseeable future. And as we develop those strategies, I look forward to engaging with some of you on this panel to help us think through how we can partner to more effectively really meet the needs of the communities, the same communities that we're trying to help. Thanks.
So much, Celina. Dr. Jaff.
Thanks, Dr. Gupta. Good morning and welcome, everybody. Thanks. It's an honor to be on this panel. My name is Michael Jaff. I'm actually a vascular medicine specialist, and I just joined Boston Scientific in January after having spent 16 years in Massachusetts General Hospital in Boston, and for the last 4 years running a community hospital within suburban Boston. And throughout my career, it's been striking to me how challenging it's been to include patients who are in underrepresented minorities, Black, Hispanic, Latino, women, in trials in vascular device iteration and innovation. For example, I've spent a lot of my career on steering committees and executive committees of federally funded randomized clinical trials, where we overtly stated at the start of the trial that we were going to enroll 1/4 of the patient population at a minimum who were in those underrepresented groups, since quite frankly, we don't really know how to optimally treat those patients with limb and life-threatening vascular conditions. And we embarrassingly got to about 4 or 5% of the population. There are lots of reasons for that. I hope we get into that during our discussion. So I joined Boston Scientific in January. Timing is everything. In mid-March, when the world stopped and the company had to pivot on a dime, as all of us did, we were followed by these terrible events that plagued us around the country. One of the largest facilities in Boston Scientific is in suburban Minneapolis. And so when George Floyd was killed, it had a major personal impact on a large number of employees within Boston Scientific. The company stood up the following day with statements admonishing this type of behavior and calling out racism and the need for overt anti-racism. It followed on the discussion of a project that the company started 15 years ago called Close the Gap, which is designed to actually raise awareness around racism and promotion of people in the workforce who are from underrepresented minorities. So that's been 15 years in the making. What Boston Scientific did since George Floyd's death has tripled down on their efforts to go at this issue front and center. And one of the things they did, Dr. Gupta, was they divided into 5 work streams around this issue. And one of them is on healthcare disparities and reducing healthcare disparities. And I'm honored as a new employee of the company to be asked to lead that charge and look forward to talking about how that dovetails with health, cardiovascular health, and the future of healthcare through innovation. So thanks again for the privilege.
Thank you, Dr. Jaff. Thank you for that. Dr. Thompson.
So good morning, everyone, and thanks for having me on such a distinguished panel. I'm Kweli Thompson. I work for Medtronic and currently lead our cardiac resynchronization therapies business. Just a little bit about Medtronic, which is a very mission-driven organization, really founded on the principles of about 6 tenets. The primary tenet being around alleviating pain, restoring health, and extending life. But as we look at all of those 6 tenets, a portion of that is really characterized around being a good corporate citizen. And as we've thought about kind of disparities in care, one of the things we kind of return to is just access being one of the most significant challenges for healthcare organizations kind of around the globe. Within that access category, I think one of the things that Dr. Jaff alluded to earlier, we think we have to get to some of the more structural changes or challenges that exist. And some of those structural challenges have primarily to do with access. One of the areas that we focused on quite heavily is just how we bring our innovation to market. And in medtech, which is a very regulated environment, a lot of what you have to do to bring your technology to market is really go through clinical trials. So Medtronic has focused pretty heavily on trying to increase the diversity in our clinical trials, both from a sex perspective as well as from an ethnic minority perspective. I've highlighted to you previously 2 examples, one for our simplicity trials, which focus on hypertension. At the very outset, one of the things we wanted to focus on is really increasing the representation of African Americans in those clinical trials to match that of what the disease state represents, around 21, 22%. Likewise, as we look at cardiovascular disease, specifically around cardiac resynchronization therapy to treat heart failure, we have a clinical trial in which we've boosted the percentage of women enrolled in the trial. For cardiac resynchronization therapy, women tend to respond more favorably than men, yet they represent much lower proportion of patients who are treated with that therapy. So adapt response, we've managed to enroll about 43% women. And part of what we're attempting to do is to kind of continue along those trends with increasing representation in our clinical trials. A few other things just to highlight, getting at some of those structural challenges. Similar to what Dr. Jaff has highlighted, being a good corporate citizen, Medtronic is really focused quite heavily on addressing some of those social determinants of health. And a lot of what we've been able to garner, social determinants of health, a large percentage of those are really characterized by where you live, where you work, where you play, where you pray. And so getting at some of those structural challenges, we're collaborating or at least working with institutions within communities. Northside Achievement Zone, one locally here in Minneapolis that we partner with, which really aims at getting to kids in the community as early as possible, providing support kind of from an early age. Likewise, I think we are collaborating with the Thurgood Marshall Fund to address kind of the college-age population. And then as we look further on, I think as Celina mentioned, partnering with organizations like WomenHeart, like the Association of Black Cardiologists, and the National Minority Quality Forum as well, to get at some of these other components. So we've got a pretty broad approach. At the core of it is how we develop our technology, which I started with. But as I said, it's multifactorial, pretty complex, and really getting to some of those structural challenges is one of the things that we're taking close to heart and being a good corporate citizen as well.
Dr. Thompson, thank you. Last but not least, Dr. Stoekenbroek.
Thank you so much, Dr. Gupta. It's a pleasure to be here, and in a you know, amazing panel of other panelists. So thank you so much. So I just want to take a more of a general look at cardiovascular disease, and we all know that risk factors for cardiovascular disease are much more common in certain populations than in others. So, and for example, in 2017, African Americans were at a 20% more likely to die from heart disease than non-Hispanic whites. And we now also know that COVID affects certain populations more than others, which makes it all the more urgent to address health disparities, including in cardiovascular disease, especially since the long-term cardiovascular consequences of COVID are not fully clear yet. And I think we are just at the beginning of realizing what technology can do for society to improve health equity. And two topics that we at Novartis, and also just me personally, are very passionate about are increasing diversity in clinical trials and improving adherence to therapies. So regarding the diversity in clinical trials, I think that a starting point, something that is very critical, is that every decision maker realizes why it is important for new trials of novel therapies to reflect the population that the therapy will actually be used in. And it should not be an afterthought. Diversity has major implications. So for example, we now know that ACE inhibitors work less well in African Americans than in white people. And we also know that the clinical benefits of ticagrelor over clopidogrel extend even more in Black patients than in white people. So studying the drug in the wrong population might lead to clinically relevant differences in recommendations on how we use certain therapies. And if that isn't enough, there are actually costs associated to treating people the wrong way. And regarding the adherence, the second point, we now know that underserved populations are disproportionately affected by poor adherence, especially to chronic therapies, such as those often used in cardiovascular medicine. And we know that as a multifactorial problem with both patient, physician, and system factors. And technology really provides us with a tremendous opportunity to take certain components out of the equation, ranging from simple medication reminders to actually developing new therapies that are able to overcome some of the limitations of therapies that are associated with poor adherence to therapies. So with that, handing it back to you, Dr. Gupta.
Thank you, Dr. Stoekenbroek. You know, what I'd like to do is, and for all our viewers, we're going to have a discussion for about 30 minutes until about the top of the hour, and then move towards a Q&A. But so I just wanted to flag, if you do have questions, please do ask it in the Q&A box, and we'll try to get to as many as possible, maybe more if we just based on timing. There are an excess of questions I want to ask this distinguished group, but in staying true to the purpose of our seminar, I want to just start right out of the gate with, can you speak, I know all of you are working in a variety of interesting spaces with regards to innovations in improving cardiovascular outcomes. And we can define what that means. You know, for Dr. Jaff, it means one thing. For Celina, it means another. Different focus areas in that broad umbrella category. Can you speak to? So you're working on initiatives right now. From my own work in this space, I know there's a lot of great activity happening with connected devices. But one thing that always seems to be lacking is proven efficacy. Does it actually improve patient outcomes? A connected device and their cardiovascular health, for example, does wearing a physical or a activity monitor improve your health? I think there's some early signals it does, but it's still unclear. Can you speak, can each of you identify, and maybe I'll start with Celina, something your organization has done or is working on in the final stages that you think is showing to be effective in improving either the mental health well-being or the cardiovascular well-being of patients?
Thanks for that question, Dr. Gupta. I mean, I think fundamentally WomenHeart exists to meet the mental health needs of women with cardiovascular disease. You know, we are not AHA, you know, which obviously can give you the latest and the greatest information around cardiovascular disease for women. But what we are is a way for women to connect with each other. It's really the peer-to-peer model, and in particular women providing support to other women that drives, that sort of, you know, was sort of at the very founding of WomenHeart, what was the impetus for the founders to create it in the first place. And so to the extent that we have data, it's really about how attracted women with heart disease are to our model. And we do have some good evidence that, for example, the numbers of women that have sought us out has increased during this time. And so we know that, especially because women or anyone with heart disease is of a particular risk to COVID infection, they're more likely to be isolated, which obviously ups the stress and anxiety having to do with, you know, with that isolation. And so connectivity is the best we can do right now in the virtual world. I mean, we continue to hope that at some point in the future we can go back to in-person support. But I think that, you know, in the absence of that sort of clear ability to do so, this is the best that we can do. So I'm not sure. I mean, that you're right. That's a very different question that you're going to ask the other panelists around efficacy of you know, that sort of connectivity. But for us, it's really about connection and community, and less necessarily about the efficacy in terms of clinical outcomes for a patient.
Thank you, Celina. I'm going to change up the order here. Dr. Thompson.
Thank you. So it's a very good question. I can highlight a few things that we're doing in the short term. I'll speak directly to kind of our business that's focused primarily on heart failure. So much of our therapy is actually built on either remote monitoring or being able to program devices remotely. And those are actually technologies that have been around for quite some time. Ironically, you know, there's always been a little bit of a resistance to kind of adopting those technologies pre-COVID. What we've seen kind of in the current environment is kind of an acceleration or willingness to kind of move into heavy remote monitoring and remote programming of devices. So we're seeing increased adoption of that technology with our current platforms. As I alluded to previously, there's always kind of been a paradigm to test these devices before they're approved, and then to monitor them in kind of a post-market or post-commercial setting. And I think those two paradigms are where we do collect significant amount of evidence. And so as we're shifting into seeing better adoption of remote monitoring, remote care, we're collecting data to kind of warn out the efficacy of those. As I said, many of our devices currently, you know, that we leverage from a remote monitoring perspective, we know that remote monitoring translates into better care. It's just honing in on specific therapeutic areas like heart failure, and then demonstrating the efficacy in those areas. So again, we're seeing increased adoption of the remote care, and in the process of collecting that data to borne out the efficacy of doing that.
Thank you, Dr. Thompson. Dr. Stoekenbroek.
Yeah, thank you, Dr. Gupta. So, so we all know that medicine basically moves on evidence. So I think that generating the evidence that novel strategies actually work is just critical. I would actually like to give you two examples of some of the things that we at Novartis are doing. So the first one has more focus on the type of therapies that we are developing. So we are now focusing on the development of new therapies with basically less frequent dosing regimens. And we know, for example, with statin therapy, that adherence to statin therapy is extremely poor and patients discontinue. So we know that even among the highest risk patients, so those with a recent myocardial infarction, I believe about 50% of patients stop their statin therapy in the first year after treatment, and many more actually just forget taking their pills, because obviously taking a pill every day is something that can be difficult for a lot of people. So one can imagine that less frequently dosed therapy, so for example every month or even less frequent, have less risk of basically the patient forgetting to take their dose. And if you move toward even less frequently dosed therapies, you can even start to think about, for example, administration not by the patient but by the healthcare professional. And that is something that is obviously in other therapeutic areas already adopted. So think about, for example, osteoporosis, but also, for example, the supervised medication taking in tuberculosis. So basically that takes the adherence or the forgetting to take therapy out of the equation. So that is one important thing that I think has major benefits for all patients, but especially for the patients who we know are at increased risk of being poorly adherent to their medication. And the second example that I would like to give is not so much on the therapy, but more on the technology and how we can potentially use technology in a more strict definition to improve adherence to therapy. So I remember a conversation that I had with an expert a while ago, and that expert basically told me, you at Novartis, you have two ways of putting a therapy on the market. It's either going to be a new drug, or it's going to be part of a comprehensive care intervention, and that is basically what all stakeholders are increasingly looking at. So one of the things that we are currently considering is basically doing a trial of one of our therapies combined with an app that basically supports not just adherence to our therapies, but also adherence to other therapies that the patient might benefit from. And not only the adherence to therapies, but also taking a broader look at a patient's cardiovascular disease risk. So for example, giving the patient the opportunity to monitor their blood pressure remotely, and tracking their physical activity, and basically circling back with that information to both the patient and to the healthcare professional, to ensure that the patient has basically that all-round support to increase their cardiovascular risk profile. So those are two examples of things that we at Novartis are looking at.
Thank you. Very interesting. Thank you, Dr. Stoekenbroek. And Dr. Jaff, please.
Well, I have to say that Dr. Thompson's got a real advantage here because his field of interest has been technologically way ahead of the vascular space. However, let me try and make my case here. So patients in the disorder I care for as a vascular doc, leg artery blockage and the inability to walk distances because their leg hurts when they walk due to lack of blood flow. That's a direct link to all sorts of other serious cardiovascular outcomes, such as heart attacks, strokes, aneurysm ruptures, and even blood clots. And so the ability to improve walking distance and being able to measure that improvement in walking distance is directly linked to not only reductions in hypertension, reductions in hypercholesterolemia, glycemic control improves, and even an overall sense of better well-being, that they can do things with their families and friends that they wouldn't otherwise be able to do. They can maintain their occupation in an effective way. And so using a wearable that simply, Dr. Gupta, can measure walking distance and walking time, both before and after an effective therapy, is of great value. That can be shown with very simple techniques like supervised exercise. You don't need a fancy device or expensive medications. Supervised exercise has been shown to markedly increase walking distance in patients with artery blockage. However, for those who can't do it because their disease has progressed so far, or in underrepresented minorities who don't have access to a supervised exercise program or can't afford to participate, or whose insurance won't cover it, and they go on to a procedure, the ability to monitor walking distance and walking time and walking speed is of huge value. Now, I know there are lots of wearables that can do this, but it's a really important metric. And just to add to this, the more advanced form of this artery blockage is called critical limb ischemia. That is, those patients who, if you don't do something to improve their blood flow, they might in fact lose their leg. And that's a disaster, not only from obviously the severity of that procedure, but the unlikelihood that most people will be able to ever walk again effectively, and that their risk of having a contralateral or the other limb being amputated over the next couple of years is over 50-50, and that they'll die far more often after that amputation than people with major cancers that we worry about. And so the ability to monitor people's blood flow through wearables, and that works ongoing right now, could really make a difference between someone being able to go through a simple procedure just to do wound care, orthotics in a shoe, home education, to losing a limb and dying.
Dr. Jaff, I'm going to start with you and throw back a question. You know, all these, all the interventions discussed here would improve cardiovascular health in the community, either from a mental health standpoint or from just from a day-to-day physical activity standpoint, which would in turn then improve one's mental health. I'm wondering if I wanted to prescribe my patient who was underrepresented or didn't have durable access to healthcare, or transiently out of work. What's the ability? Talk to me about payment models for the interventions developed at Boston Scientific, and then if we could go down, I'll prompt the other panelists. But I'd love your thoughts on who's paying for the wearable for somebody with PVD or PAD.
No one. No one's paying for the wearable that I'm aware of right now. There may be some commercial insurance plans that have special relationships with employers in which those things are offered. But if you take the average person, let's say a Medicare-aged person, the good news is, Dr. Gupta, that Medicare does cover enrollment and participation in a supervised exercise walking program. That is a benefit added to a Medicare recipient. However, again, as I said, a lot of patients don't have access to those types of programs. They're not on every street corner. Not every cardiac rehab program offers this. So it's a real limitation. I think the other concern that you nicely highlight is if we had the ability to monitor someone's blood flow to their foot, which, by the way, that wearable technology exists today. There isn't a single commercial insurance plan that I'm aware of that would pay for it. Some of that may be because the clinical trials haven't been completed to show its benefit.
Dr. Thompson, I'm going to throw it to you next.
Yeah, so I'll clarify one quick thing. So I'd say most of our devices, at least within our implantable space, are implanted. And so that's covered by, kind of the insurers, whether they be national or private. To Dr. Jaff's point, the wearable component, I think, is a different domain altogether. And then I hate to keep going back to the same area. Dr. Jaff highlighted this as well. Most of the common reasons for denial around payment for many of these things is just they haven't been borne out or proven from a clinical research standpoint. And so I think as things evolve, it's going to be incumbent upon, us and the folks that are making the wearables to kind of include these into clinical trials. And I think we're seeing more of that. We've got implantable devices that are phenomenal at detecting things like atrial fibrillation. As I said, those are covered kind of in the typical framework of either a national insurer or private insurer. Beyond that, I think we've seen more and more instances of things like Apple Watches trying to detect things like atrial fibrillation as well, and doing, I think, broader, innovative type clinical trials to kind of understand that. Getting that to a point where it's convincing for an insurer to say, yes, it's good enough for us to ultimately cover it or to pay for it, I think is the next, the next step. And I don't think we're there quite yet.
Dr. Thompson, I'm just going to quickly follow up, and the other panelists, by all means, please chime in. And it's hard to do sort of interactive engagement on Zoom here, but I'd love to try to foster that. I know you said that clinical trials are lacking. Is that something that's actively being addressed? So in the development, I recognize that there's the FDA process to get something to be considered a medical grade device for deployment in real time. But is there a different threshold? It sounds like there's a different threshold between medical clearance by the FDA for a medical grade device and convincing a private insurer, for example, to subsidize the cost of a wearable device, for example, for their enrollee. Different bars, and is that one? Is that your understanding? And well, so, two, is it? Yeah.
Yeah, I was going to say it probably depends, right, on the private insurer, but for sure, getting an indication kind of at the national level, you've got to pass that threshold for the FDA or whatever country kind of you're in. But as it pertains to, you know, what you were speaking to earlier, if indeed I can demonstrate that there's, you know, tremendous benefit from a cost efficiency perspective or from an outcomes perspective, I think, you know, there are instances where insurers are willing to work if there's a broad enough impact to understand, you know, if deploying a wearable technology will help with optimizing outcomes in a specific disease state. I think those efforts are still ongoing. You take something like heart failure, which is so multifactorial. You know, there are a host of things that you can deploy to try and assess the ultimate well-being of a patient in their home. And as I said, you know, sometimes there's willingness to try those things, but ultimately it comes down to does it improve their clinical outcome by leveraging or using this technology in a remote setting? And that's, I think there are efforts ongoing to do that. And in terms of the different bars between the FDA and private insurers, it depends on the private insurer that you're working with.
Dr. Gupta, I would just jump in and say that one of the opportunities that exists in society today at this moment is if we actually tried to gain more information about the impact of these wearables in cardiovascular disease among patients who are not routinely included in clinical trials. That could have a real impact. And so, for example, one of the ways to do that, and I'm sure Kweli and the other panelists agree, is to get investigators who are not routinely included in these clinical trials, who manage large populations of patients from underrepresented minorities to participate. And then you add in a wearable and you start to even get subgroup analyses that can show impact and differences in outcomes. Then you've got momentum, particularly at this time in our society, I believe.
Yeah, I couldn't agree more with Dr. Jaff. I think if you think about where the problem is, right, the problem of things like poor adherence and other opportunities, they exist more in certain populations than in others. And if we study those interventions in the wrong populations, it all comes back to, you know, you won't see that much benefit. So we have to tailor these trials and tailor these interventions to the populations that they will benefit most from them.
Well, WomenHeart's certainly ready and willing to be a good partner along those lines. But I just want to quickly intervene here and talk about the fact. So in my previous life, I ran an organization called the Global Alliance for Chronic Diseases, and we funded implementation science research. And you know, I think that is another frontier that we're about to kind of embark on, because what we're really talking about is behavioral data, everyday behavioral data collected by wearables. And so we're going to start to move away, I think, from RCTs out of sheer necessity to get scale, to get numbers that we're talking about, you know, in the millions. And we all know how expensive RCTs are. And the reality is that if we don't sort of expand our idea for what valuable data looks like beyond gold standard, we're not really going to achieve or come to the solutions that we're all looking for.
Yeah, it's super interesting. We I think about this a lot. So the traditional approach is, of course, to do the traditional double-blind, placebo-controlled trial. And while that is obviously necessary to show that a drug works, once you have shown that a drug works, the next step is to show that it actually works in clinical practice. And that also allows you to uncover some of those limitations. So for one of the therapies that we are working on right now, we're actually going to do several phase 4 studies. So after approval, to collect more evidence. And we are basically, as you said, going to do this in the form of more implementation trials to study the effects of the therapy that we're developing on things like adherence and what happens to the background therapy if a patient starts our new therapy. So those are some important questions that will really help us uncover some of the opportunities to improve the actual implementation of our therapies. And one of the ways to improve that implementation is through technology.
Doctor, thank you all for those comments. I wanted to ask, I think, a related question, and which is, and then get to audience questions. If you had a conversation with if this was a policy-making audience, elected officials, either at the federal, state level, let's say federal, what would you tell them are the most important legislative priorities that you would wish they would prioritize to make your lives easier, to improve community cardiovascular outcomes? I'll kick it off to Dr. Jaff, and then please just everybody.
Well, let me start off by saying, wow, that's a loaded question, but okay. So first of all, I would give them a couple of stats, right? I would tell them that Blacks who live in the southern United States have a 3-fold increase in limb loss than whites in the same exact region, and that they've seen all of these same kind of disproportionate adverse outcomes in COVID. And so if there isn't a time on earth or in this country that we need to address these healthcare disparities by learning what works for these patient populations and then actually providing that care to patients in those populations, there will be no better time. I mean, I could go on and on, but I'll give others a chance here. Well, then, maybe for Celina, just to double click a little bit on that, if you had a specific ask of say the Senate or Congress more broadly, both houses, what would it be? Would it be specific initiatives, moonshots on to address the gap in clinical research so that we could actually convince insurers and payers more broadly to subsidize all the innovations that are happening in this ecosystem? I'm wondering what is the specific ask you'd want?
I think for me, it follows along what I just said around implementation research and talking about a new standard for acceptable evidence to then approve it to get funded, right? Let's say in the CMS world or whatever. So we've done that, for example, now. I mean, you have telemedicine visits that are covered by insurance, but that took some time, right? And then this pandemic really kind of highlighted the need for that. So we're seeing kind of the matching of the need out there based on, you know, this very huge crisis. Well, we've got this crisis already, this sort of, you know, slow moving crisis in the context of CVD across the population. And implementation research and sort of increasing funding from implementation research, and then using the results coming out of implementation science to then make good decisions about approving, you know, different wearable technology and other types of technology, I think could be a really important next step in terms of legislation.
I don't want to co-opt Dr. Stoekenbroek or Dr. Thompson from answering these questions, but I'm curious if you know touch on that if you'd like. But what I'm wondering is what is the willingness, in your view, of people, of patients to or communities, underserved communities, to actually utilize innovations, digital innovations? Do you feel like people are willing? Is there a captive audience out there? Or are they skeptical? Mm-hmm. You know, I think about contact tracing, for example. I know that's different. It's not cardiovascular outcomes per se. There's all privacy issues. But anytime you talk about tech or digital health, more broadly, I feel like it raises the specter of privacy invasion or suspicion more broadly about using any type of technology for healthcare. Do you feel that way, Dr. Thompson? What are your thoughts on whether people would be amenable to trialing? I know in your case it's CRT devices, but just the full landscape of innovations.
Yeah, it's a good question. I guess I'd harken back to kind of where I started from the access component. We're talking about kind of a point in time when we were speaking last week, where we highlighted the current pandemic has exacerbated, or there's a big bright light that we're shining on underlying disparities that have existed for ages. And so I think getting back to those fundamentals and just providing access or getting to individuals in their communities, meet them where they are would be my first stance. And that may be leveraging wearables and technology. It may not be, but I think you got to start from a position of saying, let's first and foremost provide access. My simple answer to your previous question was just, let's provide access to folks. Let's not make it more challenging for them to get care. And so I think if we start with that, I think we can build on getting folks to be a bit more comfortable with leveraging technology to care. I don't think it's just, you were highlighting examples that are probably, you could generalize those statements for a number of folks. It doesn't just have to be ethnic minorities. There are a lot of folks that are hesitant to kind of use technology. And so I think when it comes to the disparities aspect, I would just say, let's meet folks initially where they are. And sometimes that's just showing up in the community, so to speak, and facilitating a framework in the community to provide care. And I think we'll grow from there.
Thank you. Dr. Stoekenbroek, any thoughts on the range of what we were just chatting about, either legislative priorities or concerns about uptake of innovations that are happening at Novartis in communities that you're targeting?
So I think regarding the second question, I totally agree with Dr. Thompson. I think it's a matter of meeting people where they are, and I think it's a matter of designing technological innovations that basically don't scare people, right? Health is a very sensitive topic, so I have a little doubt on whether introducing an innovation such as putting an Alexa or the health equivalent of an Alexa in someone's home might actually work. And I think people use apps, people use iPhones. I think people are much more comfortable using that kind of intervention than something that is much more revolutionary. In my experience, it's a little bit too early to say about whether such apps linked to specific therapies that we are developing would actually work. But that is what we're studying, and I think that is where it all should start, and doing those rigorous trials to collect that information. Regarding the first question about the priorities for legislators, I think one important thing, and this is also something that Dr. Thompson alluded to in his introduction, is that this is such an intricate issue, disparities in care and how technology can be used to solve that I think it needs more than just one organization at a time to basically address it. And I think it's typically the kind of problem that needs to be solved by multiple organizations working together with regulators to basically make decisions and move the field forward. So I think that is one area where I think there's a lot of room for improvement.
Thank you, Dr. Stoekenbroek. We have about 6 minutes left, and there is a question from from the audience I'd like to touch on before we make some closing remarks. And that's from Paul Underwood, and he asks, what do you feel can be gained by increasing minority participation in clinical trials, and what can be done to improve minority access to trials? That was a question. Actually, I was thinking the same thing. I know the rates of minority enrollment are low. Wondering what you think, anything from incentives to other sort of creative solutions could be done to fundamentally address the solution, not just sort of a patchwork approach. I'll throw it to, I know Dr. Jaff, you had wanted to touch on this. Give you the first shot.
Thank you. Yeah, this is a key issue, and I think it has to start with, as I mentioned earlier, getting investigators who manage large panels of patients in underrepresented minorities to participate as trialists. It's not as easy as it sounds, but it's really critical. The truth of the matter is, if these patients' physicians don't even know about the trials or are not interested in the outcomes of these new technologies in their patients, the patients won't agree to do them. There's mistrust already, as you suggested. So having their own doctor be the one to say, look, I think this is so valuable to your health that I'm an investigator, and I think it's reasonable for us to consider your enrollment, that's going to have a blockbuster outcome for these patients. So I think that's got to be job number one. And that's going to require infrastructure. It's going to require education, right? If you don't have a research nurse, if you don't have a relationship with your IRB, if you don't have support from your practice or institution, it's going to be very hard to do this.
Thank you. Thank you. Any other thoughts on that from the panel?
So I think it all starts with having the conversation with the investigators, right, and with the institutions that you're working with. I can imagine that for many of those large institutions, if you don't have the conversation and if you don't hold them accountable, it is not something that they're going to do on their own, on their own initiative. It is having the conversation, providing them with the data on the demographics of the patients that they're including, so that they can actually see what they're doing and holding them accountable that way. I also think that, as Dr. Jaff just said, is we know that often providers with a certain background have a higher proportion of patients with a certain background. So choosing investigators in diverse populations will allow you to increase the diversity in your clinical trials. I think another major barrier is just the way that clinical trials are set up in terms of the reimbursement for patients. So if you think about very practical things, like usually a patient gets a stipend for participating in a trial, and often that stipend comes only after the visit or even after the trial has concluded. But we know that, for example, for a patient who is, let's say, out of work or has certain financial restrictions, going to the study site, traveling there, paying for the parking fee and things like that are just very practical barriers to participating in trials. So making sure that reimbursement happens before the patient actually arrives at the visit could be an important way of taking away some of those barriers. So very practical things, I think, are important.
Dr. Gupta, I would just add that I think a really critical component of this, because essentially what we're talking about is increasing trust. And a lot of patient advocacy organizations play that critical role in being a translator and really trying to bridge that trust divide. And so I would encourage anyone who's trying to increase different groups of underrepresented communities in clinical trials to engage with organizations like WomenHeart, because that's what we do. Right? We try to make it, we try to understand the experience of the patient, as well as try to inform them when it really makes sense for them to get involved in things like clinical trials.
I'd just add to that. I think Celina raises a fantastic point. Goodness, maybe about 5 to 7 years ago, there was a big impetus around patient-centered clinical research or outcomes. And I think getting to that involved, one, collaborating with patient advocacy groups, but also starting to include that type of representation as you're designing some of these big clinical trials, to understand what things do you need to do to bridge that trust gap that you have with patients. So I think she's raised a great point.
Thank you, Dr. Thompson. Thank you, Celina. We are within 60 seconds of, I know there needing to be a break between us and the next session. So I just wanted to, first of all, thank Celina, Dr. Jaff, Dr. Stoekenbroek, and Dr. Thompson for your time. I wanted to thank everybody on who viewed this panel and tuned in. Thank you for your questions and for your attention. I will work with the forum just to make sure that I guess Kiko, if will there be access to a recording of this if folks would like to re-review it at some point?
Yes, once the recording is finished, we can upload it to our NMQF YouTube website where everyone can view it.
Excellent, excellent. So, you know, from my standpoint, I think a few take homes and among the many, but number one, to really broaden access to connected devices, other types of innovations and technologies to improve cardiovascular outcomes. You know, clearly we need more implementation science research to help really answer the question of how do we get payers to pay for these innovations so that these tools that are amazing from all these world-class companies get embedded to the places of greatest need. It's already happening. We already have fantastic leaders from these organizations doing that work, but how can we scale it? How can we help them, frankly? And so that's that iterative dialogue with our leaders. And of course, clinical diversity is another issue, or diversity in clinical trials, rather. How do create a pipeline there that we're not constantly, I feel like this is a constant struggle every time, whether it's vaccine trials or device trials, where we're just never able to crack that code. So how do we wrestle with that in a more meaningful way? And I think dialogue is really key. But with that, I just want to say again, thank you everybody for your attention and your time. And thank you again to our panelists for all the incredible insights you've shared today. Thanks,
Thank
everybody.
you.
Thanks, everyone.
A pandemic brought the world to a halt. But thanks to you, we're finding new ways forward. Your comfort and care push us to do even more. Your generosity reminds us what matters most. And your courage inspires us to find better solutions for tomorrow. On behalf of all Novartis employees, thank you.